Welcome everyone to today's webinar. I am Emma Beamer with Becker's Hospital Review. We will begin today's webinar with a presentation, and we will have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We are looking forward to hearing your questions. Additionally, in about a week following the webinar, we will be sending out a copy of the presentation to the email you used to register. At this time, it is now my pleasure to turn the floor over to Chris to begin today's presentation.
Thanks very much, Emma. This is Chris Storr. I'm the Chief Marketing Officer at Twine Health. Thanks very much for joining us today. We're really excited about this webinar. We have some great folks on the line with us from Penn Medicine, and we're really here to share information, but then also answer your questions. So don't forget to ask those questions in the questions widget and go to webinar. So with us from Penn Medicine today is Megan Mariotti. She's the Assistant Director of Operations at the Penn Medicine Center for Healthcare Innovation. Megan designs and executes projects and provides oversight for center operations, including staffing allocation and business development. Penn is actually very, I'm sure, happy to have Megan back, where she received her nursing degrees in bachelor degrees in nursing and master's degree from nursing from Penn before moving on to the Harvard School of Public Health, where she also did some work in our backyard in Cambridge, Massachusetts. We're obviously very proud of that. And Megan's also worked in some of the most prestigious institutions on the East Coast in Atrius, Geisinger, and New York Presbyterian. So Megan's got a really nice pedigree in medicine from across a number of different systems. Nicole McHenry is also joining us today. She's a registered nurse who joined the University of Pennsylvania Health System in 2010. Nicole joined the Penn Medicine Center for Healthcare Innovation in 2015 as a participant in this program that we're actually going to talk about today, which started off with a year-long proof of concept before becoming a full-blown program. But again, we'll get more into that. Nicole has actually received rave reviews from everyone on her team and patients alike, and because of that incredible work, and really phenomenal results that we'll also share, Nicole was the recipient of the first ever Twine Health Coaching Excellence Award. So we have some real experts in the field joining us today. And if that's not enough, Nicole is also currently pursuing her BSN from Westchester University, and the two of them are on a kickball team for Penn. So very exciting stuff. Lastly, John Moore is CEO of Twine Health. He founded Twine in 2013 following 6 years of PhD research at the MIT Media Lab. Prior to that, John got his MD and a degree in biomedical engineering from Boston University. And I will gladly skip over my non-existent bio. So as we get into the webinar, we'll cover a number of different topics. We'll hear some information about the Penn Center for Healthcare Innovation. We'll then dive into some very practical insights about how to turn primary care from kind of a traditional resource for healthcare to something that is wrapped all around great outcomes, and then the results of this program that Penn's put on, as well as information about how we're helping accelerating behavior change with technology. And lastly, if you do have questions, just enter them into the GoToWebinar panel, and we'll try to get them either during the presentation or afterward. But there are a ton of folks on today, so you might want to get that in quickly. And with that, I will turn it over to Megan.
Thank you, Chris. So I'm going to start by talking a little bit about Penn Medicine and the Center for Healthcare Innovation at Penn. So Penn Medicine is the oldest health system in the country. It was founded in 1751. And it also has a long-standing history of innovation, having founded the first medical school in 1765. Today, our Center for Healthcare Innovation is led by Dr. David Asch, who was quoted in an article in the New England Journal of Medicine last year titled "Innovation as Discipline, Not Fad." And you can see on the screen, he was quoted saying that innovation, or healthcare innovation, is not about iPhone apps. It's about a disciplined approaches to rapidly testing new ideas to promote better patient care. And that's really what we're trying to do here with this program, is to test new methods to improve care and sort of partner that with technology. So you can see up on the screen now the triangle graphic displays the goals of our Innovation Center and the relationships to each other. So our aim is to make people healthier, and to us that means not only improving patient quality of life and better outcomes, it also means reducing the burden of disease. So we're doing this in a number of ways. We're doing this by trying to make care a part of people's everyday lives and finding effective ways to deliver care in order to reduce costs. Lastly, we strive to make innovation possible as quickly as possible, and we really do stress that sort of doing things as quickly as we can to help providers and other systems across the country adopt these innovations. So that's partially why we're here today, is because we wanted to share this program with all of you. So the employee hypertension program started initially as a year-long pilot last spring to develop a proof of concept, as Chris said, for treating patients diagnosed with hypertension. As the name indicates, the program was created specifically for employees of Penn Medicine. Given that we're a self-insured employer, we're at risk for total cost of care in our patients. So this makes sense not only from a financial standpoint, but it also gives us a runway to try and develop programs for fully risk-bearing populations, as many of us in health systems take on more risk for our patients. So for the initial pilot, we opted to focus on one condition, hypertension. We know from estimates using both claims data and just general population health estimates that about 2,700 employees in our system have hypertension. I do want to mention that like any other employer, this information about our employees is de-identified. So this is really just an estimate using the information that we have. We did, as we tend to do, we set a very lofty goal for this program that 100% of participants would reach a healthy target blood pressure within 3 months of the diagnosis. So we defined that target blood pressure as less than 140/90. And again, this is for patients with previously uncontrolled hypertension. So I do want to stress this point here that we from the start, we set quantifiable goals, and this is really important to us so that we're measuring everything from the onset. We started measuring at the very first patient that we enrolled. Our approach with the program, as you can see, is to eliminate barriers for patients to achieve target blood pressure. We took a number of varying steps to do this, utilizing new strategies to engage patients, variations on primary care workflows, and approaches to enhancing relationships. We use technology to support those relationships, and through this collaboration to maximize patients' contribution to really become and sustain self-efficacy. So you can see the title today involves the word hacking. Hacking is not a term that is commonly used in healthcare. It's definitely not one that I commonly use. So while the term hacking is used more commonly when talking about modern technology development, the concept in healthcare is relatively new. So in literal terms, hacking is a technical effort to manipulate the normal behavior of network connections and connected systems. Now, I did not know that. I had to look it up. Hacking in healthcare is similar. So you're trying to change the existing healthcare network, in this case primary care, to achieve a more favorable outcome. And this is what we've done in this program, certainly while leaving the existing primary care relationship intact. So what we'll share with you next is a compilation of some of the best practices that we've learned from our effort to manipulate the current way in which hypertension care is delivered. Throwing away some of the things that we didn't think were working and testing new concepts to achieve outcomes. So I'm going to walk through a number of hacks, and we'll start with the philosophical belief in the patient. So our efforts started with a really simple principle that patients are often underutilized members of the care team. So the typical process is pretty familiar and may be familiar to many of you. Patients are diagnosed with hypertension, they're given a prescription for a medication, and they're told to come back in some time frame, maybe something like 3 to 6 months. So for some patients, not surprisingly, they leave the office. Sometimes they fill their med if they can, sometimes they don't have time. others fill their med and then they might stop because they feel better. And then often when the patient comes back into the office, their blood pressure is no better off and they can go through the same cycle again. So we took a different approach when we thought about the employee hypertension program. We geared everything around maximizing the patient's contribution, from eliminating barriers to access right from the onset to supporting them between visits to better understand and manage their condition. Okay, the second hack is that we have a collaborative care team, and you can see this photo of our care team here. Our team has actually grown since this photo was taken, but it includes a physician, a nurse, a medical assistant, and some staff from our innovation center to work with the team on piloting new concepts. Because this is a different model, we were really deliberate in selecting a multidisciplinary team to help evaluate and iterate every step of the process. One of the most important things about this team is their willingness to do things differently and to really be open to trying new things, which I think for many people can be a hard thing to do when we're sort of used to doing things a certain way. I know it is certainly for me as well. We wanted to make sure that we kept the patient at the center of everything we did, so we knew we needed this team of different backgrounds and disciplines to think outside the box. Hack number 3 is related to how we are enrolling these patients, and this is something we really continue to learn about as we go. As I mentioned earlier, we knew from our estimates and claims data that we had about 2,700 employees with uncontrolled hypertension, but we didn't know who they were. So we have tested and we continue to test different approaches to engaging patients and to enrolling them. We learned that some of the approaches that we tried at first, things like sending out email blasts and hanging posters and things, wasn't necessarily the most effective way to enroll people, that just seeing the information or getting an email about the information wasn't always enough, that sometimes speaking to and engaging with patients was really a more effective way to enroll them. So we really got out into the community and into the Penn Medicine community and have been screening people and meeting them where they are. So specific tactics that we've used have included advertising at our biometric screenings, which I know many systems have, utilizing things like health fairs, partnering with occupational health to have sort of partner with them to have them share information about our program. And then, as I said, some of the most effective tactics have really been the in-person screening. Even just walking around with a blood pressure cuff and asking people if they wanted to have their blood pressure taken when they're at lunch or things like that. I've been doing things like that pretty regularly. But I'll also add that likely our best enrollment strategy has been providing a really good experience to patients because they share their experience with other employees that they sit next to and work with every day. And so we're really focused on making sure that the people who are enrolled have a positive experience, because then they'll go out and talk about it to others. But I will say that we're really continuing to learn about what the best ways to market are, and we're definitely open to ideas. So I'm going to pass this over to Nicole McHenry. Nicole, as Chris mentioned, is a registered nurse and is really at the center of this entire program. She's the star of this show, I would say. Nicole's responsible for most of the interaction with patients, both in the office and then between visits when she communicates with them. I will note that Nicole has never had formal experience previously as a health coach, but she certainly picked it up quickly, and she hasn't looked back.
Thanks for the introduction, Megan. Hi, I'm Nicole, and I'm really happy to share my experiences with you. As Megan mentioned, I'd never done this type of work before, acting as a health coach, but it turns out to be something that I really enjoy doing. So when a patient reaches out after some of our marketing approaches, they contact us either over the phone or through an email, we make sure to set them up with an appointment immediately. And this is sort of where the patients first get introduced to our multi-team approach. From the moment a patient steps into our office, Donna, she's our medical assistant, she checks them in and makes them feel welcome and comfortable. She lets them know that we're really happy to have them there, and that's where we start encouraging them to be, the patients themselves, to be a part of their healthcare. The patient's then brought back to the exam room and given a brief overview of our program. And we explain here that this is an added benefit from our health system. We do a quick BP check and then get a brief health history. From there, I give Dr. Rusk, he's our medical director, a snapshot of the information that I gathered. And Dr. Rusk does a quick history and physical, orders labs, and then we decide on a treatment plan together. We talk about what's going on in their lives, who's important to them, and what their own health goals are. I try to understand what words they use and the possible root causes of their high blood pressure. I try to start a relationship with them and just let them know that I'm there for them and will be by their side for their entire journey. As part of our approach is to remove barriers. That's sort of, I think, what we do the best. We're able to provide on-site care, which is huge. As we know, it's hard enough to take a day off from work, let alone to take a day off and then spend 4 hours in a doctor's office to get your blood pressure managed. So we're able to offer the on-site care. Right now, we're able to provide medications to the patient at no cost. We're able to provide them with free remote monitoring via Twine. And we also give them an easy-to-use at-home blood pressure machine. And all of this eliminates the economic and time constraint burden of the patient getting the necessary tools to start them on their journey of managing their blood pressure. The next step is an important one. I set up each and every patient on the Twine coaching app, and together we set blood pressure and other behavioral change goals as part of their own action plan. Everything is unique to the patient. So somebody may say, I want to increase my exercise, and I've had patients say, I want to stop eating potato chips. So it really varies to it is very unique. We might have a patient who is planning to run a 5K or get in shape for a wedding or just simply to eat better. So while our overall goal is ultimately to lower their blood pressure, we make it extremely personal using goals and even words that the patient feels passionate about. It's really important to note that these action plans aren't a year long. The first action plans are just 2 weeks or a month, and they typically start with very simple goals like measuring their blood pressure twice a week and logging their blood pressure medications. While these are intending to be simple, patients typically achieve 3 things after the first month. They're actually thinking about their condition after they leave the doctor's office. They feel that they've accomplished and learned something and now understand blood pressure a little bit better. And if they do these things, they might actually see their blood pressure drop by a couple of points. This education, self-awareness, and goal achievement are the first steps towards self-efficacy. Additionally, on the technical side, during the first visit, I make sure the patients know how to use Twine. I ask them to send me a sample message so they can see how it goes through and how the whole process works. And this is our attempt to make sure that a patient isn't going to give up because they don't know how to use the app. Once the patient leaves the office, they self-monitor at home, entering their blood pressure readings in Twine. They also indicate when they complete other health actions, like taking their blood pressure medication, exercise, or maybe healthy eating goals, limiting tobacco. Each of these actions and even lack of acting informs me as their coach about how they're doing, so I can reach out to them in real time at the moment that I get the data point about their activity. I send them a quick, secure message in the app. I congratulate them when they've had a good reading or completed a health action. I motivate them with messages of support if they've had a bad reading or haven't completed their health action. Even inactivity is an indication of a need that I need to reach out to them. The Twine dashboard makes it really easy to keep an eye on my entire patient panel. I know who to reach out to, who's doing great, or maybe who is falling out of compliance that might need some additional outreach. Each week, the clinical team, we run the list, which gives us all the opportunity to talk about the patients and keep track of them remotely, allowing less frequent visits. All of this is really important to help me be completely efficient. Otherwise, trying to keep tabs on my entire panel would be really difficult. Over time, as patients build out a profile of their action and behavior change, they start to see entwined the correlation between their health actions and their blood pressure readings. They start to see very quickly for the first time how what they do has an immediate impact on their health. As I mentioned, in the first couple of weeks, they'll start to see immediate improvement in their blood pressure. In fact, within only a month, a third of previously uncontrolled hypertensive patients reach target blood pressure. So as patients are collecting data, Twine has a feature to allow patients to compare their health markers with actions through visualization. So for example, they can actually see the correlation between taking their blood pressure medication and their blood pressure reading. Patients aren't just learning about hypertension, they're seeing how their body responds to various things in real time, which is so cool. Again, I use this information to show patients their progress and congratulate them. Soon enough, we move from helping patients reach their goals to sustaining those goals. Once the patient is sustained a goal, they require less health coach feedback, ultimately allowing me more time to help the new patients in the program.
Okay, so this is Megan again, and we're moving on to my favorite part, which is the results of the program. So I'm going to share the results of the program to date and give you a little bit of information about where we're going next. So Nicole talked about using data on the individual patient level, but we also are able to look at aggregate data from Twine to help us understand sort of the bigger picture and look at trends to see how we're doing. So I have two graphs that I'm going to show you. This first one shows the average blood pressure over time for patients in the program. I'll note that what's not shown here is month 0. So every person in the program started out with a blood pressure greater than 140/90. That's sort of a requirement for entry into the program, is that they're uncontrolled. So what you see here is a pretty quick decline in their average blood pressure that's maintained over time. And you can also see that the patients who have been in the program for the longest, which is 14 months at this point, have an average blood pressure of 113/74, which is pretty incredible for somebody who's previously had a high blood pressure. It's a pretty nice looking number. So according to the American Heart Association, for people at age 50, total life expectancy is about 5 years longer for people with a normal BP than for hypertensive people. So it's nice to know that this effort really could have an impact on people's lives. I got one more graph for you, so bear with me. This graph is a slightly different way to look at it. This shows you the percent of patients at target blood pressure. So moving away from the average, it just shows you out of all the patients enrolled at a particular month, how many of them are in control. And the way that we've defined that is less than 140/90. So as Nicole mentioned earlier, we started to see some patients achieve target blood pressure in just 1 month. And then you can see improvements. At 2 months, we've got about 80% of people at target blood pressure. At 3 months, 90% at target blood pressure. And at 4 months, 94% at target blood pressure. So I have to call myself out because earlier I stated that our goal was to get 100% of patients to target by 3 months. And we're at 94%. So haven't quite achieved our lofty goal, but we're still working at it. We're pretty happy with the 94%, but we really constantly continue to refine how we work with patients to improve that number. So it's still the goal. We have not moved it. I also, from this graph, want you to note that if you look over time, you see pretty sustained targets. So, I was just talking about 3 months, but if you look out over time to, 12, 13, 14 months, you can see that people are sustaining this target blood pressure. Okay, moving on from the outcomes as far as blood pressure, we also measure employee satisfaction with the program. We send out a really simple 4-question survey to assess patient experience. And one of the questions that we ask is a Net Promoter Score, which is used in many industries outside of healthcare, but this really measures a user's loyalty, not just satisfaction, and it can be used as an indicator for growth. So the actual question that we asked employees who had been enrolled in the program for a certain amount of time, we said, how likely are you to recommend this program to a friend or colleague? Every single person that answered the survey gave it a 10 out of 10. And we just resent the survey because it was time to send it again to get some more feedback. And one of the things that I wanted to note was they actually have to move the little cursor from 0 to 10. It wasn't just sitting at 10. So there was some effort there. It wasn't the default. And so this is actually the best possible net promoter score that you can get. It's 100, which is what this program received. And doctors like to get 100s on things, so we're very happy about that. I will just say, just for a reference point, that net promoter scores vary widely from industry to industry. And creating benchmarks isn't exactly a science, but just to give you a reference point, Kaiser Permanente scored highest in the industry in 2015 with a 31, which was 19 points higher than the industry average. So not an apples-to-apples comparison, but just to give you some reference. And I actually Googled Net Promoter Score to see what other industries get. So you can look at what do hotels get and what do like Fitbits get and things like that, in case you're interested. So a little bit about where we're thinking, where we go from here. We talked earlier about how this started as a pilot, and we completed the one-year pilot in June. So once we presented this to our leadership, we showed them our data, the results that we just showed to you, and it's been picked up as an official program, so it's no longer a pilot. And we really want to engage more Penn Medicine employees with uncontrolled hypertension. So to support this effort, we've increased health coach time, so we have more of Nicole's time, and we brought on additional physician time so that we have more capacity for employees. So they, initially with the pilot, they could come in on Tuesdays, but now they can come in on other days as well if that doesn't work for them. We're also looking to expand our reach geographically, thinking about going to other sites, and are in the process of thinking about targeting other conditions such as hyperlipidemia, which we have found coexists frequently with hypertension. So as you can see from much of the data that we just presented, the program has been a great success. Our patients are really reporting excellent experience, and we have a team that's committed to continuing to provide this care while we expand the program. For a number of the reasons that we described earlier, such as a really user-friendly dashboard, ability for patients to track their progress, for the clinical team to remotely monitor patients, Twine has really been an essential tool in making this program successful, and we're happy to be working with them. So I'm going to hand this over to Twine CEO John Moore, who's going to share a bit more about Twine.
Well, thanks so much, and I appreciate your kind words, but it's really great to have Nicole and Megan here. I haven't met them before in person, so it's quite inspiring. Now that I'm not on the front lines practicing medicine anymore, I get to live vicariously through them. And I think they were a little modest. A 30-point drop in blood pressure in 1 year is about a 500% improvement over the standard in primary care, which is about a 6-point drop in a year. And they were able to get 90+% of patients to go in 3 months and 100% at a year, or at 14 months. The norm is 30% in a year. So it's really spectacular work that they've achieved. And we're glad to be here with them to tell you a little bit about our small role in that process, but hopefully something that is attractive to a lot of you who are thinking about doing similar programs. Having the scaffolding of technology to support a program like this helps you to measure it more effectively, scale it more effectively, and helps the most important piece for us, which is empowering the patient to really activate and engage at their fullest. So this first slide is just really talking about that, emphasizing just how far the patient is out of the picture in typical care. And what we do here at Twine, which is is part of the language that is out there and the movement is happening of putting that patient at the center of their care. But how can we take that even further? How can they not just be at the center of the care, but really driving the agenda and feeling like they have command of the situation and are getting support from the healthcare system? So it's almost an inversion of control there that we try to help support here at Twine, and that folks like the team at Penn are doing. They're putting that patient in the driver's seat and giving them the ability to work with coaches and providers and their family and pull together data from devices and other experiences that are key in helping them to master their health. And at Twine, we've worked hard. It's almost a decade's worth of work now, through research studies and then through collaborations, to think about how to make this as simple as possible. It's challenging to switch to value-based care. It's challenging to think about new team models of care, or it used to be. Now, with tools and with experiments like this that have already proven themselves, and having done that about 30 times over, we can pass on that experience and provide the scaffolding to deliver a program like this really easily. To reinforce what some of the software features are, it's really about co-creation with patients. Having patients have the agency in making their decisions is really key, because it's what they need to live with on a daily basis. So being able to work with their coach to create something together that they both think will maximize success is the starting point. From there, that co-created care plan supports the patient on a daily basis, not just in reminding them, but really helping them to reflect and learn, and to do so in collaboration with their coach. That teachable moment becomes relevant right as it happens. Timeliness is one of the most important things in this new model of care. It's not about waiting until some scheduled interaction. It's about being there when people need it. People have complex lives, and the social determinants of health are the biggest barriers to people with hypertension and diabetes and cholesterol. But being there for them helps them to succeed. And it's about convenience. Again, patients have a lot of priorities to manage, and healthcare falls at the bottom of that many times. But if we can lower the friction so that we can be there right when they need it, it makes a huge difference. And that gets people to their goals in the end. For them to be able to get back to living their life, feel as if they have this problem now under their thumb. So it's not just about technology. It's really about a new relationship. It's about feeling in control of something that was otherwise invisible or difficult to manage. Now it feels like it's under your thumb. It feels like you have someone there to support you, and you can always stay on the rails. Now, part of this is certainly technology that can help, because you couldn't imagine managing blood pressures flowing in from every patient every day without the ability to see, well, who is doing well with their adherence and who is not doing well with their adherence. How is that trending? How are they doing with their measurements? Is it trending better? Is it trending worse? And how are they doing with their communication? Has someone really fallen off the path of communicating with you, or are they really ramping up and have more needs? So having the artificial intelligence in the platform to sift through all of this data and make those assertions allows this to be a really human relationship, because now we're not clicking away and sorting through there. Instead, it allows each coach to provide the right care for the right patient at the right time. Also key to that is being able to care for the whole patient. Although the team at Penn is focused on hypertension, that doesn't mean that their interactions with them weren't looking at the total care of the patient and really understanding the challenges that they're up against, whether that's other medical aspects, whether that's social aspects, whatever the patient needs to succeed. And many of our customers over time may start with a single condition but then start to expand and really address the patient's diabetes and their hypertension and the depression. Because if you're not dealing with the depression or the other issues, the motivation there to really change the behaviors will not be achieved. So that's a big part of Twine, being able to have a holistic view of the patient and not just be focused on a single program. And then the other piece is really to have real-time insight. This is a brave new world, right? We're not in the world of just the fee-for-service encounters anymore. Now we're providing care when people need it. Well, we need to understand how much time are we spending? How satisfied is the patient? How's that correlating with outcomes? How can we maximize all of those, but still maximize the affordability of healthcare? And what we've been able to show at Twine is that using a tool like this not only allows you to get back to the heart of that important relationship, but it allows a single coach to care for about 3 times as many patients as they would be able to do with scheduling office visits and with hanging out on people's voicemail and hoping that they've heard that. It's not that it eliminates visits, but it allows us to do the right thing at the right time for the right patient. We have published a number of randomized controlled trials in our prior work. So a lot of our work with Penn and others has been inspired by some deep research. So a randomized controlled trial that was conducted with the Massachusetts General Hospital showed an average 26-point drop in blood pressure in 3 months and an estimated 35% decrease in the total cost of care for hypertension in that population. And then another randomized controlled trial that has been published as well with the Joslin Diabetes Center showed an average 3.2 drop in hemoglobin A1C in 3 months for patients starting basal insulin. And in this, there was an estimated decrease in cost for total cost of diabetes care of about 40%. And as a rough comparison, the average drop in hemoglobin A1C in a year for patients starting basal insulin is 0.5 point to 1 point. And for blood pressure, as we discussed before, the average drop in a year is 6 points. And our colleagues in the hypertension study were able to achieve a 26-point drop at 3 months. So thank you very much. This was very exciting to have the team from Penn here. And I'll turn it over to Chris to start the Q&A.
Great. We've got a bunch of questions come in, some very heady topics, so we'll dive into some of those and some of the more straightforward ones. Just a quick question in terms of managing patients. For the average patient, how much time does it take to help them reach their goal, and then when they sustain it, what does that look like?
Like minutes, like I'm not sure.
Yeah, in terms of maybe number of interactions or how many minutes on average for a month or so.
Twine actually is able to track how much time you spend each month, or I think it's in 30-day increments with the patient, but I haven't really paid attention to what that number is.
Okay, we've got our data analyst signaling on average 5 minutes.
The last time we had looked, over the course of a month, it's around 12, 14 minutes per patient per month.
But I would just add that the first visit for the patient tends to be something like 45 minutes in total, and that's split between the physician and Nicole as far as the time that the patient is spending in the office. And then any follow-up visits are typically pretty quick in less than 15 minutes.
So this is actually a great question. Not all patients have the clinical knowledge needed to properly identify or manage their hypertension. They don't know what they don't know. How is this overcome so they can ask relevant questions and make proper decisions?
So actually, great question. And a lot of I think maybe it's assumed that Penn Medicine employees have a broader idea of what hypertension is, but we see everybody from janitors to surgeons, so not everybody has a good idea of what hypertension is, and a lot of that is explained at that first 45-minute to an hour visit between our entire team meeting with them. I think they're able to piece together what what each of our teammates have to offer, and they get a very good understanding. With that being said, it's a lot of information at once, so once they go home and have time to digest it, it's very easy to just send a message through Twine and get sort of an instant respond. And I feel like Twine also allows it to be like, I'll say, less formal, and like if you just have like a quick question, the patients feel comfortable just shooting over, as silly as it may seem, as opposed to if you were gathering your questions for a doctor's appointment, you may feel less inclined to ask something that just popped into your head.
And the other thing too, I think that maybe helps people to learn more is that they're checking their blood pressure pretty frequently themselves at home, so they're getting to see more. They're getting more feedback. The feedback loop is there because they're checking it with an automated cuff and then putting the number into Twine so that Nicole can see it.
Yeah, I mean, I think it's a good point you raised earlier, Nicole, is that it's not just about the kind of patient receiving information; they're part of it, and so the knowledge transfer happens from doing these activities.
Right.
There's a couple of data questions here, and I think I'm reading this correctly. So the question is baseline blood pressure, either or 140/90, and I think that's for the control. I think it's both had to be below. Is that right?
No. So we would define a high blood pressure as either systolic or diastolic being over 140 or over 90. So if one or the other is high.
But we typically require the patients have 2 ratings.
Right.
What we like is when they come, not that we like it, but when they come into our office, they're higher than 140/90, and we have 1 or 2 documented readings of them being 140/90 previously.
Yeah.
And just for people on the phone, Nicole, this is Megan and Nicole, and we're sort of finishing each other's sentences. So it's both of us talking. You should see us on the kickball field. We're a strong team.
Another data question is how big is the sample size?
Oh, so I think that there were denominator numbers up on that the graph that we showed earlier. So right now, enrolled in the program, we have just under 100 patients.
Well, we have just under 100 actively engaged. I think we had like 105.
Yeah,
total.
In total we've got 105, sure. And so, obviously not all of them have been enrolled since the beginning. So we've been enrolling them throughout the course of the year, but that's our total as of right now.
So I'll throw a bigger question out there, and this might actually consume a little bit of time, but we'll see what happens. So excellent initiative, well done. What are your thoughts on how to scale this service to the wider primary care user, i.e. those outside of OCHealth and private payer schemes? And how do we get local national government to pay for this? So maybe the second part is, that's probably its own, forget webinar, that's its own class probably.
Well, I like that. You saw that our goal was lofty, so I like the lofty question as well.
So I think from the first standpoint, this started as a pilot and now it's a formal program. What are the things that you're thinking about doing to try to scale this beyond this initiative and incorporating other primary care?
Well, I'll let you take it. Go ahead, Meg.
Okay, jump in as needed. So this is a question that we've been asking ourselves, I think, certainly. And as I mentioned earlier, we're testing a number of things as far as marketing goes. So with some initiatives that we do at the Innovation Center with our employee population, emails are a really effective way to communicate. But as I said earlier, we've realized that the personal touch, giving people the opportunity to ask questions and things about the program is more effective in this case. So we're trying to identify partners to work with who can help us to refer appropriate patients to the program. I mentioned working with occupational health. For example, occupational health tends to touch most employees throughout the course of the year for things like flu shots. So, one thing we thought about is could we partner with them to screen for blood pressure when they're getting flu shots? Many of our employees participate in biometric screening, so is it possible that we could just sort of be there and if somebody has a high blood pressure, we can offer to enroll them in the program. And then we're also looking to partner with, potentially think about strategies like partnering with PCPs to encourage them to refer appropriate patients. As far as scaling to the wider primary care user, I'm actually going to let Nicole talk about that a little bit, because Nicole and John talk about that a little bit, because I think what's a little bit different about our model is the fact that the nurse is actually spending a fair amount of time between visits communicating with patients, which is a little bit different than what we see in many primary care practices. But I'll hand this to John.
Yeah, so I think a lot of that question stems because of the payment model, right? Where you have the affordance to provide this kind of care with an employee population because you're responsible for the total cost of care. So what we see in the market today in terms of how to then take this and then spread it is health systems often start with their own employees. What we then see is a lot of health systems that start selling a narrow network service of new primary care and health coaching to employers in the surrounding region where they contract directly for a scope of services where they are responsible for the total cost of care. And then the third component of that is looking at the general population and taking on more risk-based contracts. Now that they've proven it with their own population, then they've scaled it to the next level through some narrow network offerings to employers in the area. Then they're seasoned at this. They know how to deliver highly cost-effective care where they take risk for total cost. Then they're willing to take on more accountable care contracts in their general population. And that's what we generally see from health systems as a staged approach to navigate this brave new world of value-based care. Now, outside of that, there's a huge movement across the country in fully capitated primary care. Even Medicare and Medicaid have experiments going throughout the country with membership-based models of primary care. So it's not far off that commercial payers, Medicare, Medicaid, and others will be exploring and scaling full risk models of primary care.
So I think that answered about a half dozen questions, which is pretty good. So there is actually a pretty keen eye that caught this one, and I think this is actually a good question. I noticed that there are a few dips in blood pressure compliance from 94% to 83%. Do you know why that was, and is it something that can be predicted and avoided when onboarding new patients?
What's popping into my mind is not knowing at what time of year that dipped down. I feel like we noticed it also, and I feel like it was around the holidays. I think that we said that it was like Christmas Eve, Thanksgiving time, and then when it went back up into the 90s, we were like, oh, this makes sense. It's like the new year, and everybody's like, making their New Year's resolutions to take control of their health, and but not knowing the exact. I think that was the reason.
Okay. What percent of blood pressure results were driven by taking blood pressure medications? This is probably, I don't know if we can actually have exact, because there's so many interventions going on, but I don't know if that's something we can address.
And do you know how often you, in your program, have been changing the medications, or do you feel like the diet and exercise component has been really pivotal?
Yeah, we absolutely encourage lifestyle modifications, but I would say that I would say a large majority of our patients are on medication. What that exact number is, I don't know. I would say 90+% of our patients are on medications. At that first initial visit, we, go over in very detail the lifestyle modifications that can be made. And we've taken patients off medication. A lot of patients have this fear that once they start taking medicine for their blood pressure, that they're on it for life. And we've stopped it on 2 or 3 patients that have made lifestyle modifications in one way or another and have come off.
So I can speak a little more generally about data and Twine. What we see in hypertension in particular is about 75% of patients are able to achieve goal blood pressure solely by adhering to the medication that they were already on and making diet and exercise changes. It's only about 25% of people that require an increased dosage of any of their given medications as a net change in order to reach that goal blood pressure, which speaks so highly about how important the patient contribution is, that many times what's seen in these programs is that people didn't know that they needed to take their medication every day. They thought they needed to take it when they had a headache, right? We know that patients retain about 20% of what's said in the office. That's just because it's typically a short encounter. It's not experiential. It's more just absorbing the fire hose. But once you start experiencing it and working with a coach, you tend to retain the information and learn it much better. So that's the gist of what we see in the population. About 75% of patients can succeed without any medication changes, 25% require. And in the randomized controlled trial that we did, there was a net increase of a half of a dose of medication. So it wasn't like they were adding lots of new medication.
And I think anecdotally, pharma actually recognizes this. There was an article recently where somebody from Novartis was interviewed about possibly using coaching in clinical trials. And the biggest concern that was raised was that coaching might have too big of an impact and make it look like the drug was performing better than it actually was because of the personal attention to the patient. So that's pretty interesting.
We actually had a patient come in and tell us that she only took her blood pressure medication when she ate bacon. Like she thought that was the only time she had to take her blood pressure medication.
Probably a good idea.
Yeah.
But it has to be an amazing experience to have that experience in healthcare where the patient actually gets off of the medication within such a short duration of an intervention to be able to get them under control and get that off. That to me, when I've seen that before, patients get really inspired, and then they move from their hypertension to another condition to say, I can defeat this now. I know that I have the power to do this. It's inspiring.
So we got a question earlier on, and we may have kind of addressed this, but we'll bring it up in case somebody else has a question, because it is something common that we hear, is can Twine be used for anything beyond hypertension? John, you can.
Sure. So we, across the country now, we have partners that are using Twine for diabetes, hypertension, cholesterol, depression, COPD, prenatal care, the list goes on and on and on. People are people, and health is challenging no matter what condition you're dealing with. And the reality of it is most of the time, it's the social challenges, it's the social support, it's also the timely medical support that gets lost because it's too much friction to make an appointment and get there. So what we find is an approach where no matter what medication or no matter what measurement you're doing or what kind of lifestyle change you're doing, whether it's quitting smoking, etc., this kind of supportive coaching approach, scaffolded by technology, yields very similar results across all of these conditions, but not only conditions, but health optimization situations, right? Prenatal care is not a condition. It's where you're trying to optimize your health during that situation.
Okay, this will be probably a two-part answer to this, but are the devices that patients use, i.e. the BP cuff, connected to Twine, or do they have to enter the information manually?
They have to enter the information manually into Twine. So they're taught at that first visit how the blood pressure cuff works, and then we get that reading, and they're taught then how to enter the reading into Twine. I think that this is an important part of it because the patient acknowledges it, and it's real to the patient. It's not just me telling you your blood pressure is X. It's them seeing it and entering it, and then, in my opinion, further motivating them to control it.
Yes, Twine does support wireless connected devices like glucometers and blood pressure cuffs, etc. Thus far, we don't have any evidence that wireless devices improve the patient outcomes. And there was a very interesting study that was just published in Weight Loss that showed patients using a connected device versus just really focusing on the social support of a intervention like this. The people using the device that was wirelessly connected actually lost less weight, which was a really interesting finding. But across the population of people using Twine, some are using connected devices, some aren't, and the results are equally powerful in both situations.
Great. In order to achieve better patient engagement, what is the ideal patient ratio per doctor or coach, or what have you experienced to date? And I think anecdotally we can share some information on the studies that we did.
So we are in the process of trying to expand the program. I think, I said we were at about 100 patients now. I think we are able and have the capacity to take on more patients given the time that we have. I know we've talked about getting to about 300 patients and then feeling like we might need another coach but I don't know if Nicole, if you want to add anything about.
Yeah, I mean, so for the first year, we had one doctor and myself and our medical assistant, and but now we've expanded. So there's 2 other doctors, but I don't have an exact number to say how many patients a doctor can. I will say that it's sort of nurse-driven. The doctor's input is in as requested by the nurse.
And Nicole, you thus far have not been 5 days a week full time.
Right.
That's correct. How much of your time is dedicated right now?
So it was 1 for the first year, and now we're up to 3 days, 2.5 days. Yeah.
So most of this data is based on 1 day a week.
Correct.
With 100 patients.
Correct.
So 500 might be a stretch, but possible. Yeah. With this level of results, and 300 probably easy.
Now that she has more time, so it's hard. I would say it's hard to say for us right now. It's something I think we're going to learn as we go. And what's the point where we feel like this feels like it's too much and we need to bring someone else on? But I feel like for now that's not an immediate concern. That moving past 100 is going to be too much.
The typical studies in coaching with a full-time nurse dedicated to coaching, with that only doing it through office visits and phone calls, is that if they're working 40 hours a week, they can only manage 100 patients. So you are already doing that 1 day a week. So nice work.
So there's a question about the cost savings that we highlighted in the Mass General and Joplin studies. Is cost figured by the number of patients on the program, size of organization, or anything else, monthly maintenance fees, et cetera?
So those numbers are total cost of care analysis for the particular condition. So we looked at office visits, phone calls, messages, et cetera, in both the control group and the experimental group, looked estimates of medication adherence and what the pharmaceutical costs would be, and we looked at the attainment of goal blood pressure and national statistics about what is the total cost of care for a patient whose blood pressure is not controlled and what's the total cost of care for a patient that is controlled. Involved the cost of the technology in there as well, which is negligible compared to all of those other costs, and did the analysis in that way. And anybody can certainly come to our website and download those publications to read into more detail about that.
All right, so that's it. It's 1:59. There are quite a few questions that we did not get a chance to answer. So what we'll do is we'll try to reach out to folks after this directly and answer these questions. Otherwise, feel free to send an email if you didn't get a chance to enter it. But with that, I will thank everybody very much for your participation, especially Nicole and Megan. This has been a lot of fun, and hopefully we can do it again soon with some additional data. All right, thank you very much. Take care.
Thank you.